All right. So what do you guys think of the presentation?
That's good.
Yeah,
It was
very
interesting.
informative.
Yeah, she does a really good job. Just want to recap on some things for Amanda's presentation. So her content, I just opened it up on Canvas, so you'll see her PowerPoint there. Just make sure when you were taking your notes, did everybody change that dosage for the medication for ceftriaxone from 250 to 500? Did you guys write that in your notes? Yes, no?
Yes.
Yes.
Okay. Okay, thanks. So just make sure you make that change. So what's one of the key takeaways you got from screening? So if a client comes into the hospital, into the emergency room, and it's standard across the board that we have to ask everyone if they feel safe, right? What if you have a gut feeling just from something you've seen, something seems suspicious or whatever, the way the body language, how would you be able to screen that client?
Like one of the things she said, like if they have to go for a test, like go with them to get them alone and see if you like they'll open up to you then.
Excellent. Yep. So even if they don't need something, like you could even say, I have to do, exam, but sometimes they'll say, oh, that's okay. I'm her spouse. I don't mind. Right. So even, just saying, I have to take her to x-ray, I have to take her for this, and you really don't, it's okay. So, getting them away from that person that I'm going to just call them the perpetrator for lack of better words. So getting them away from that person, that perpetrator, and asking them while they're alone. I wanted to just kind of give you some key pages in your textbook. Uh, it's definitely in chapter 4, but it's also in chapter 5 and 19. So if you look in the back of your textbook, if you look under intimate partner violence, it's mentioned a couple times, and I just went through my book just to kind of share a few things. So on page 81, which is in chapter 4, they have a little blue box. It talks about intimate partner violence, in parentheses, abuse. So it talks a little bit about what it is. So I know she gave a definition of what it is. And then on chapter 5, if you go to page 105 in your textbook on chapter 5, they talk about the adolescent, teen pregnancy. And she also alluded to this, that teen pregnancy, it has an increase in violence. As a matter of fact, it says adolescent girls experiencing violence in a dating relationship were 4 to 6 times more likely than their non-abused peers to have been pregnant, and 8 to 9 times more likely to have attempted suicide in the past year. So you see that with the adolescents, that and then it mentioned on page 154, because it's kind of scattered throughout the book, but it's going to be on your exam, so I want to just kind of go over it. And then she also talked about intimate partner violence and pregnancy. Does anybody remember some of the things she said about intimate partner violence and pregnancy?
Like the risk factors are substance abuse, end up with inconsistent prenatal care, and it can be preventable,
Mm-hmm.
and it can increase depression.
Right. And go ahead. Good job. And anybody want to add anything else to that? So it also increases the risk for preterm births as well. Preterm births are more likely in the presence of intimate partner violence, mental health issues, substance abuses, than women who are not in an intimate partner violence situation. Maternal exposure to domestic violence is associated with a significant increase in low birth weight and preterm births. Also, like you said, inadequate prenatal care. higher incidence of high-risk behaviors such as direct physical trauma, stress, and neglect are postulated as well. And then one other thing on page 567, which is in chapter 19, they actually, and I think, is it 567? Yeah, well, 567 talks about the link, and she also discussed the link between LGBTQ persons and an increase in domestic violence. So for screening. And then in chapter 19 on page 603, let me get to that one here. On page 603, they go into a lot of detail about intimate partner violence as well. So it is testable material for your exam. So I just wanted to go over that with you. And I had her reiterate the collection of evidence. So key points in the sexual assault exam, and what is the time frame that they can collect the evidence?
96 hours.
96 hours. And what are some of the things that we need to know about collecting the evidence? And I kind of asked her, I reiterated it before she left. Like when you're collecting the evidence, what do you want to tell the client?
To bring like any clothes that they have that they may have been assaulted in. They're going to check under their fingernails or swab any areas of the body that may have been touched by the perpetrator.
Excellent. And also, one of the myths is that showering destroys the evidence, and it does not. So just letting them know that even if they showered, it's okay. And then the medications, there's a pretty lengthy list of medications. So they're administering in the hospital, in the ER setting, ceftriaxone, which is now increased to 500 milligrams, and that is for the prevention of gonorrhea. Metrodiazole, which is also Flagyl, and that's 2 grams for the prevention of trichomonas. Azithromycin, 1 gram for the prevention of chlamydia. Plan B, and that is for the prevention of pregnancy up to 72 hours. Reglan, 10 milligrams for nausea because of all the antibiotics. And then the post-exposure prophylaxis is up to 72 hours. And then at that point, they need to have HIV testing. And that is the PEP is for HIV, prevention of HIV. So a whole list of medications. All right, let's go in. We're going to go into chapter 5. I have a couple things I'm going to do ahead of time before we go into chapter 5. Just some housekeeping things. Stay on top of the assignments, and I kind of things I've been kind of saying all along. Knowledge, it's rigorous. Our program is very rigorous, but knowledge is key. So just stay on top of it. Letting things kind of get behind can be difficult. So time management. Clinical wise, assignments are due before post conference. I think everybody's been pretty good about that. Just a reminder that failure to submit an assignment before post conference will result in a clinical makeup. So if I sent myself or one of the adjuncts sent you an email and said that you didn't submit anything in time, or you didn't show up for post conference, that you have a clinical makeup. And I would just kind of say, you wouldn't want to leave the clinical unit with your work not done. So you wouldn't want to, leave an IV that need to be changed, or not give a medication that was due to be given, that sort of thing. Again, just remember, when you're on clinical, even though it's virtual, if we're on virtual clinical, it is still clinical. So just kind of maintain the same ethical principles that one would maintain when they were in a face-to-face setting. I haven't really had a lot of issues, just a couple things that the adjuncts brought to my attention. So just, if you were on the clinical unit, how would you be, speaking and addressing? And this is just general. Please don't say I'm speaking to Morgan only. This is just a general statement that, you want to, how would you speak and how would you, act and behave if you're on the clinical unit, and be the same way that you would act and behave and speak in a Zoom environment. So just take your clinical seriously. And again, many really are. And just one last note, please check your email. I'm waiting for a couple more students to get back to me for whether they need fit testing or they don't need fit testing. So once I keep checking my email. I think I'm down to like 2 now that I'm waiting on responses. So once I have that final list, I'm going to send that roster to Lehigh Valley, and then I'll give you all your directions and so you can start getting your fit testing done. I think that's it on that.
Excuse me, Professor.
Yes.
Mary's waiting in the waiting room.
Oh, okay. Let me go in the waiting room here. Let me just stop sharing a second. There we go. Thank you. All right, let me get that back up here again. Okay, that's kind of what I was talking about right there. All right, so let's go over the quizzes. And I think we have to go over last week's and this week's, correct? I don't think I went over in my recorded lecture. I went over 4, correct?
First one, yeah.
Okay, all right. Oh, okay. Hold on one second here. All right, so let's go over. So we'll go over 6, 7, and then 5. Okay, so this was 6, 7. So the first one, a client is scheduled for an amniocentesis at 22 weeks gestation to assess fetal lung maturity. The client understands the procedure when she states a blood sample is drawn and sent to the lab for analysis. This test is an aspiration of amniotic fluid by insertion of a needle transabdominally. A catheter is inserted transvaginally to aspirate a small amount of placental tissue, or this test uses high frequency sound waves to produce an image.
Aspiration of amniotic fluid.
Very good. That is correct. Number 2, a client is scheduled for a multiple marker screen, quad screening at 15 weeks gestation to detect estimated due date, rule out placenta previa, menopause, or chromosomal defects such as Down syndrome.
Chromosomal defects.
Correct. A newly hired RN in a labor and delivery unit understands preterm labor when he or she states preterm labor is defined as regular contractions of the uterus resulting in cervical changes after 40 weeks gestation, the rupture of membranes before the onset of labor, regular contractions of the uterus resulting in cervical changes before 20 weeks gestation, or regular contractions of the uterus resulting in changes in the cervix before 37 weeks gestation.
Before 37.
Before 37 weeks.
Is that what you guys want to pick, 37 weeks? The labor and delivery room nurse knows that the administration of an antenatal corticosteroid, betamethasone, during preterm labor is used to A, decrease the risk of seizures related to preeclampsia. The next one, enhance fetal lung maturity and surfactant production, stop or halt contractions, decrease the risk of hypoglycemia in a neonate born to a mother with gestational diabetes.
Enhanced fetal lung.
Enhanced fetal lung.
A nurse is caring for a pregnant client at 24 weeks gestation admitted for preeclampsia. The nurse knows the healthcare provider will order blank to prevent or reduce seizure activity. Betamethasone, labetalol, magnesium, or methergine.
Magnesium.
Magnesium.
sulfate.
Magnesium.
All right. And good, good, good. All right, that was quiz 6 and 7. Now let's go to today's, right?
Mhm.
Okay, factors that affect maternal adaptation include all the following except. So watch out for those except ones. Nutrition, lesbian mother, woman in an abusive relationship, military deployment.
Nutrition.
Nutrition.
Nutrition,
Multigravidas may have the benefit of experience, but it should not be assumed that they need less help than a first-time mother. True or false?
True.
True. Good, good, good. 90% of adolescents who have had unintended pregnancy receive a high school diploma by 22 years of age.
False.
False.
false,
Sexuality in pregnancy is safe providing membranes are intact and no bleeding or problems, should be eliminated as it can harm the fetus, should be a discussion between the couple only, should not occur during the last trimester as it can cause a miscarriage.
Safe.
It's
Providing
safe.
membranes are intact. and no
Correct.
bleeding.
You got it. When considering cultural aspects of care, the nurse should understand we all have biases and they do not affect care. Inform the client that taboos are not valid and to follow the medical advice of the healthcare providers. Determine the predominant culture or expect the client and their family to speak the language of the nurse.
Determine the
in the
predominant
predominant
culture.
culture.
Yep.
Okay. All right, so that was all of our quizzes. So all we have now is chapter 5. I'll go back to here. Chapter 5, there's not like it's not as heavy. There's some things, and I'll kind of highlight some areas that you need to know when we're going through, but it's not as heavy as the other chapters, as you guys probably have seen from the other chapters have a lot more information that you need to know. So we're going to talk about emotional changes of the pregnant woman and appropriate nursing responses. Identify critical variables that influence adaptation to pregnancy, such as age, parity, social, cultural, and sexual orientation, and factors related to childbearing and culture. So when you hear the word tasks of pregnancy, it's these things that these concepts that the pregnant woman is going to hopefully are her goals, or hopefully the things that she's going to come to terms with by the time she is in labor. So one of the big ones is acceptance. And a lot of people are like, well, how come she's not, shouldn't that be like, common sense, like that, everyone accepts their pregnancy. And there's times when a woman does not accept her pregnancy. And I think we can all probably share on different reasons why that person might not be accepting of their pregnancy. It could be an unwanted pregnancy. It could be age, it could be life circumstances, just a whole host of things. So sometimes not every pregnancy is initially welcomed by the pregnant woman. We just got done, talking about intimate partner violence. So think about this past year, how we've for the most part, unless you're in healthcare or an essential worker, for the most part, most people have been quarantined. So think about that person who's quarantined, not in a good relationship, might be in an abusive relationship prior to the quarantine. Now they find themselves pregnant, expecting a child. Maybe the children that are at home are also victims of abuse. So now they're thinking to themselves, now, great, now I'm pregnant with another child, bringing this child into the world, to start this whole pattern over again. Some other things is the woman preparing for labor. So whether it's physically, mentally, taking classes, reading up on it, those types of things. Another task is is maintain, the woman wants to maintain control throughout labor. And that's, they're afraid of losing control during labor, losing their own self-esteem during labor. So those are different tasks. And that's what they mean by the tasks of pregnancy. Acceptance. So again, remember that these are normal physiological changes. The moods are changing, the hormones are raging. They may have nausea the entire pregnancy. They've got, they're working, they've got children at home doing schoolwork at home. So like the whole thing could be like just trying to adapt to everything. Preparing, like I said, going to classes, getting educated. Now, unfortunately, I think for a lot of pregnant women, these classes are online via Zoom. So women used to be able to at least go to these classes and meet up with other women who were, in the same boat that they are. They're, and their spouses or their significant others are with them. Well, now we're just like, these women are just like in this Zoom environment, and it just doesn't have that. It's just like we all say with, with teaching and learning in the classroom, it's better, in the classroom versus on the computer. Well, think that same thing for that pregnant woman. They have a lot of really cool things out there. They have a lot of apps that you can kind of put in, like when you're going to, have your baby. And they can tell you like what the baby looks like and what they're doing and how they're growing at each stage and stuff like that. So they have a lot of different things that can kind of help you prepare. Some women, and I put here dreams, and it can be one of two ways. It can be dreams like physically go to bed, close your eyes, go to sleep and dream about the baby, or it's the dreams that you have for that. Like, you want to have this really nice birth. You want to have an all natural birth, no medications or anything like that. So it could be, that type of dreams or dreaming about the baby. What do I mean by nesting behavior? Anybody ever hear that term nesting behavior before?
Yeah, that's usually like when they start like setting up the baby room, they'll like clean everything, they get it all set up, and like
Yeah,
they're just preparing their space.
Exactly. Yeah, so they're getting ready for that birth, and every woman does, they say that nesting behavior. I don't know if you guys heard this before. They'll say that you'll see a woman start to getting, nesting or getting ready right before she goes into labor, and you'll see them like trying to get everything ready. I had one woman, and she was like wanting her husband to go to Lowe's at like 9 o'clock at night to go get some boards to put up these shelves, because she didn't like all this stuff, like all these like little knickknacks, like low lying, that she's afraid, when the baby starts crawling, they're going to get into and everything. And it's like 9 o'clock at night, and she was trying to insist that her husband drive her to Lowe's, and she goes into labor a couple hours later. So you hear these different stories of these types of things. So, what are some other fears you think that they might have?
Not being a good parent,
Yeah.
or just
Like-
fear, like anxiety about your child not being healthy or having issues.
Good.
Fears of like the unknown, like how do I know if they're hungry? How do I know, if they need to be changed? Stuff like that.
Yeah. I know a lot of women who are breastfeeding, that's one of the things when you talk about not knowing, about being hungry, not knowing if they're getting enough, because like when you're giving the baby a bottle, you can see the baby's taking 5 milliliters, the baby's taking 10 milliliters. But when you're breastfeeding, you can't see 5 milliliters, 10 milliliters, right? So that could be hard to tell. Another one is, think about all those immunizations they get even before they leave the hospital. What immunization are they getting even before they leave? The baby, I mean.
The hepatitis.
Hepatitis B.
Right. So they're getting hepatitis. Yep, they're getting vitamin K, which is not an immunization, but I'll tell you what, there's many moms who are like, I don't know if I want them to have that vitamin K. I don't believe in vaccinations, and trying to explain to them that vitamin K is not a vaccination, right? So just those different fears, those different thoughts. Also fear of losing control. Trust in the medical field. Not everybody has that trust. And it could be unfounded, or it could be founded. Maybe something happened in past experiences that XYZ happened, and now they're, you know, they're very afraid of that happening. I know like some women had traumatic birthing experiences. So going back and having another baby is bringing back all those traumatic birthing experiences, and they're like, "Oh my gosh, is my baby going to be in the NICU, or am I going to have to go for another emergency C-section? I want to have a VBAC this time." So those types of things. Factors affecting maternal adaptation could be, and this is kind of a whole host of things. Um, their experience, and that one question for your quiz today, just because they've had a couple of children doesn't mean that you know they know everything, and doesn't mean that they're still not having fears and having concerns and they don't need help. Age, you go on the both spectrums. You're really young or older than the general, you know, usually like over 35 brings on its own types of adaptations. Um, I have a video that I'll have you guys watch on your own about lesbian mothers. So they come with their own obstacles, especially when you're going, you know, if you're going into the pediatrician's office, and how are the, you know, what's the signage look like? Are they asking how they, you know, their preferred pronouns or how they want to be addressed? So those types of things. Single parenting, multi-gestational pregnancies, socioeconomic, especially again, I hate to bring up this pandemic and the world we're living in, but so many people are without jobs. We talked about abuse with Amanda. And the last one I want to talk about is military deployment. And there's a lot of studies. I don't know if anybody has done any reading on women who are deployed during pregnancy, and it's not that they're going to be deployed during when they're pregnant, you know, when they're pregnant, but maybe they got pregnant on their deployment, or they moved with their spouse, or I know the one woman was telling me her daughter was over in Japan, and both her and the husband were both in the military. Once she found out she was pregnant, she, you know, they undeployed her. I forget what the term is. Does anybody know what you know, when they send them back? Um, so they ended her deployment, but they actually had to send her back to the States. So her husband's still in active deployment. The mother lives over here in the East Coast, and they sent the woman to California in a military area in California. So really, she had no support. Husband's in Japan, mother's over in New Jersey, and the pregnant woman is in California. So there's these different factors. Think about the PTSD and the depression that these, you know, some of these women and some of the things that they see. Do we have any military veterans in our class right now? No? So think about, some of the things that they see, they do, and how that affects them. What do you think is something that a lot of people who come back from deployment suffer from?
PTSD.
PTSD and depression, right? You know, that causes a lot of depression. So think about that depression. So we didn't get in a whole lot into postpartum depression, but think about, they already are predisposed, right? And then think about those hormone changes.
Mhm.
So
It
think,
just makes it worse. Yeah.
what's
The hor-
that?
I said the hormones just make everything so much worse. It just amplifies what's already there.
Exactly, exactly. So if you're thinking, when you're doing that assessment on that prenatal woman, or even after she delivers, and she discloses, I was just recently deployed, or I just came back from a deployment, found out I'm pregnant, had my baby and stuff like that. Many of your veterans aren't going to talk about their experiences, but just kind of keeping that in the back of your mind, and you're already, when you go to do her assessment, you're going to be really astute to making sure you're doing a really good postpartum depression, assessment on that woman. Okay. And so I just kind of added this a little bit more. Again, there's a link between mental health, pregnancy with the postpartum depression, and then you add that PTSD, so that whole component. And the uh, the the assessment that you're going to use when we assess for postpartum depression is called the Edinburgh Postnatal Depression Scale. Has anybody ever heard of that? We'll talk again, we'll talk a little bit more about that. But evidence-based practice as improving perinatal mental health care for women veterans, and they did this basically this quality improvement program trying to work with these pregnant women who have been, who are veterans, and trying to really make sure that they get the help that they need, so that they don't have not only postpartum depression, but like postpartum psychosis. Same-sex mothers and lactations. I actually gave you a little citation down there, um, from the American Journal of Maternal Child Nursing on same-sex mothers and lactation. So it's just a little study that I was reading. And I just thought I would share this with you guys. That 594,000 same-sex households, and 115,000 of those reported having children, depending, some adopted, some, got pregnant through infertility measures or however, but there's still a lot of gaps in the literature on stigmatization, on confidentiality and attitudes, and access to care. So it's if you ever interested in reading the article, I have that there for you. Some recommendations that this article had mentioned that I was telling you guys about before is that signage in the offices, in the doctor's offices, either the pediatrician's office or the OBGYN office. So having some non-discriminatory signage. So think about when you go to the OBGYN office, you usually, now you can just think of the past couple times that I've gone, or I've gone on the floor, gone on the hospital units and stuff like that. You usually see a baby, and you see a man and a woman and the baby. So one of the recommendations from this journal article was saying having some non-discriminatory signage, of some same-sex couples and families in the offices and waiting rooms, because that kind of adds to that inclusiveness. Doing competency training, whether it's in the nursing programs, whether it's when you start working, is doing trainings and competency, and just really being, culturally competent is what it comes down to. So what are some other ways you guys can think of to improve inclusiveness for the clients?
Ask them what they already know.
That's good. Yeah. So assess what they know, um, and and go from there. Good. What else? On this,
You could ask, like, if you aren't sure of their pronouns, ask them what they prefer to be called. If, maybe they have a name change, they want a different name to be called them, stuff like that.
good. And on that, I know Lehigh Valley does it. I don't know if we have any St. Luke's employees here online with us right now. I'm sure they have it also in the, when you go through in the screenings, when you're like assessing the patients or bringing the people in, do they have that now as a question? Is anybody from St. Luke's here online?
Yeah, I don't know if it's a question that we ask, but I know that now they have like quotations of their preferred name, and if they're transgendered or anything, they have up in the chart that they have a preferred name and pronoun.
Okay, so they do they're addressing it, and that's what I was looking to see. So I was pretty sure they did. Another thing you could ask them is, and I do this even like when you're talking about culture, because there's no way you're going to know everything about every culture and about every person and what they like and what they don't like. But if you show that you genuinely care and you genuinely respect, and you're asking, how do you want me to address this? What do you prefer? And if they know that you're genuine about it, even if you're not always saying things the exact right way that they want it, but you're showing genuine compassion, and asking, how should I do this, or what, how do you want me to handle this? I think that right there shows that respect. And then this next couple of slides, I just kind of go over some things through the 3 trimesters. I'm trying to see if there's anything. So, in that first trimester, that first appointment, we're doing that whole physical assessment and that whole H&P. So that's where you're going to start that psychosocial assessment, but it should go through all 3 trimesters. Because someone can start off with having, no issues in a certain area, and then life can change. Things can change from the first trimester to the second trimester to the third trimester. So just kind of anticipate, offer guidance, help to alleviate any fears, give them education, and be always on the lookout for doing depression screenings throughout, not just, in the beginning and then in postpartumly, but kind of throughout the whole 3 trimesters, not semesters. This one I'm going to let you guys watch on your own. I do have the link for you. So if you would watch this on your own, this really helps to kind of put everything I was kind of telling you and because of time and having a guest speaker, I'm going to let you watch that on your own. I have that under module 2. So if you go under module 2, I do have that uploaded. So if you guys could watch that on your own. And then these are some questions when you watch it. These are some things I want you to think about. Like, what are some ways that LGBTQ can feel they are being treated when accessing healthcare? What does the video say was higher with that community? So think about these questions. How can we as nurses be knowledgeable in needs and concerns of the LGBTQ community in healthcare? And any other thoughts? So just kind of keep that in the back of your mind as you're watching the video. The second trimester, start talking about those normal changes in sexual activity, provide information. So your quiz today asked is it okay to have sexual relations through the pregnancy? And what's the key thing? What's the key takeaway that you want to tell your client, your patients or your clients?
As long as there's no bleeding or issues, then it's safe.
Correct. Very good. And then the third trimester, encourage classes, discuss preparation. Hopefully at this point, you kind of know what their birth plan is, what they want. Do they want, if they had a C-section, do they want to try a VBAC? Do they want a natural birth? Do they want an epidural? Do they want only their significant other present? So these are those different things you want to be, and also assessing that partner's comfort also. One of the things you want to think about is how comfortable are they with that coaching role, that sort of thing. We talked about sexuality in pregnancy. One of the common concerns is the fear of hurting a fetus. So just explaining to them that baby's in that nice sac, they're nice and cushiony, and as long as anything's, no complications, preeclampsia, hypertension, bleeding, membranes ruptured, anything like that. I think we talked about that. Culturally sensitive practices. I kind of alluded to that when I was talking about being respectful. Again, culture, you're not going to know everything about every culture, but asking. And I've just found over the 30 plus years of is just asking and showing that I genuinely care. I think that's the big takeaway, and educating myself. If I don't know, I ask, I find out. And I think that's the biggest thing. And my question here was like, what are some, and this is just for you guys to share with me, what are some cultural practices related to pregnancy that might be relevant to your culture? Does anybody have anything they want to share there? No? So, I mean, some people, only the female is present. They don't want any, even the the spouse or significant other isn't present. I know other cultures where after the baby's born, they take the placenta, they want to take the placenta and they want to bury that on, there's um thoughts that they want to bury that on the property. It's supposed to, um, I want to say bring good luck for lack of better words, but just different things like that. Not eat hot coals, not eat, hot foods, cold foods, just a whole bunch of different things. Barriers to culturally sensitive care. Again, you know, education, on the part of the healthcare provider is really key in knowing what your biases are, knowing what your understanding is, and working with that client. So I wanted to share this little video, even though it's not necessarily maternal newborn, so to speak, but it just gives you a really good idea of why it's so important for healthcare providers to have a sense of cultural competence. So I thought this was really interesting. It was done a couple of years ago in Philadelphia, one of the hospitals and schools up there.
Cultural competence that's an interesting, I guess, idea more so in nursing.
I've never heard of cultural competency or competence.
Boy, you're asking a loaded question.
Everybody in the health profession should be culturally competent.
I went to a 4-year bachelor school, and there was a lessons on cultural competency, and what that really was just teaching people that there are differences, to be aware of those differences.
So first and foremost, cultural competency means being open-minded to those differences, and then hopefully having some background and understanding that those differences exist, and per the culture that you're dealing with, having that knowledge.
Rather than just all in your mind, understanding that there are differences and something needs to be done about it, but what is there to do about it? They didn't really talk a whole lot about that.
What I was taught in school is supposed to be reflective of being able to understand different cultures and their different needs. But as I've gone through nursing, I think it's a lot more than just understanding the culture needs and being competent in understanding what cultures do certain things.
But if I were to just think about what those words meant, I would think that it has something to do with being culturally conscious and sensitive to the issues that the population of people you're dealing with bring.
The way I look at cultural competency, and it's a personal sort of approach, is to take all patients and treat them with the same respect that I would want to be treated, and afford them the same dignity. And that, I think, crosses all geographic boundaries, all race boundaries, all religious boundaries, and it comes back to that, I guess, the golden rule.
The thing that you try to focus most on in cultural competency is providing the basic needs for each individual, and not just see them as a culture, but providing the healthcare as to that individual in the manner and the need that they feel is best suited for them to, for their complete and overall wellness.
Hay varias personas que realmente, yo me he encontrado con varias que no saben nada de lo que es el inglés y sufren mucho en los hospitales.
Y lo primero que caí fue con la pierna derecha. Y me duele muchísimo, ya no puedo ni trabajar.
I'm sorry, sir. My Spanish is really bad. Do you speak any English? No? Okay. I don't really understand you. Can you say that again? Okay, down here? Okay. When did it start? Today?
Ya tiene un tiempecillo que yo me sentí muy mal. Entonces, cuando fui a la clínica, no me entendieron. Entonces, pues me dijeron que fuera a sacar nueva cita. Y no fui, dije, ¿qué caso tiene que saque nueva cita si me va a suceder lo mismo? No me van a entender y nada más voy a venir a perder mi tiempo. Y ya no regresé más.
How are you doing today?
Es que me duele la pierna mucho.
My name's Kathy. I'm going to be your nurse.
Es muy importante los intérpretes porque uno lo necesita cuando uno no, porque uno puede decir me duele algo, pero a veces uno no tiene el concepto realmente adecuado al decir cuáles son los síntomas en realidad que tiene ese dolor. Entonces, realmente uno sí necesita un intérprete.
Yes, but I'd like to also see if you have anything going on up here as well, okay? Can you tell me how much it hurts? 10 being the most pain you've ever felt, and 1's just a little bit of pain. So little pain or big pain, a lot of pain.
I don't know if he's getting more frustrated or if he's in more pain.
Right.
Yo creo que posiblemente si ellos estuvieran un poco más cerca de nuestras culturas, sería para nosotros más fácil y para ellos también.
I've worked with interpreters, as mostly family members, a daughter or a son that speaks English as well as the person's primary language, and translating through them. But still, there's room for discrepancy because perhaps they don't understand all the medical terminology.
First of all, I think having materials in their home language is very important. Then they understand that even though you may not speak the language, you are there to help them and address their concerns.
And I think that's the biggest thing as far as cultural competency. You have to be a big patient advocate, making sure that, if there's an interpreter needed, that if you don't have everybody there on the same page so that message can be communicated all at one time to the individual, and not only the individual who you're caring for, but the person helping to make the decisions, it makes things go a lot smoother when everybody's on the same page.
But when you see a place like Puentes, people are treated with dignity, their issues are addressed, they're listened to, and their problems and needs are attended to, I think that that's a great learning environment, and you teach the next generation through doing.
Estaba trabajando, me caí y me duele toda esta pierna me duele.
I know you speak only Spanish, but we're going to have an interpreter come in. Interpreter. Okay? Escala du dolor. Finger, uno finger.
Hola, me llamo Rachel, voy a ser la intérprete hoy.
Ah, hola.
Hola, voy a interpretar todo lo que usted dice tal como lo dice, y si usted no entiende algo, favor de avisarme.
Hi, I'm Dr. Cole.
Hola, me llamo Dr. Cole.
So, could you tell me a little bit about what's been going on?
Entonces, ¿puede contarme más de qué le pasó?
To your heart?
Voy a escuchar a su corazón.
Pain when I press?
¿Tiene el olor cuando aprieto aquí?
No.
Y tiene una tarjeta con más recursos de la comunidad que le puede ayudar cuando sale del hospital.
Ah, muchas gracias. Gracias por ayudarme.
De nada, un placer.
Ahora sí lo entendí todo. Muchas gracias por ayudarme.
Que le vaya muy bien.
Gracias.
I gave Mr. Fernandez a card with more community resources that he can use when he leaves the hospital.
Okay, that's good. I actually got the form for emergency medical assistance, but I'm not sure if he's actually qualified for this.
Oh, well, even if he doesn't have documentation, he's eligible for emergency medical assistance.
Oh, okay, good. So I just need you to sign this, and then you can give it back to me, and I notified social work, and I also notified physical therapy for follow-up.
Great, I'll take care of this.
Okay, thank you.
Thanks.
10 veces. 1, 2, 3.
All right, so it kind of gives you a little understanding and of from a healthcare provider's perspective and from a patient's perspective. How many were getting frustrated when they just kept asking him instead of going and getting an interpreter right away?
Yeah. He's not going to understand it in 20 seconds if he didn't understand it right now. Yeah.
Right? Oh, I remember as a nurse giving chemo and having to go over everything with a client, with a patient on what the medication is, and especially the teaching points. You need to let me know, the biggies, fevers, chills, reactions, especially like the first 15 minutes of starting the chemo, and kind of going over everything. There was just so much because this person was a new leukemic that I had to go through like everything A to Z, that I wasn't even going to start until I had that interpreter in the room with me ready to go, before, because like what's the sense, right?
Yeah.
I'm not sure if they did that to film that, specifically just to kind of show that. I'm not sure what their intent was there, but anyway, I just wanted to share that with you. It kind of gives you a different perspective of it. This one I had posted. I just want to share this with you. When I was grading the CLGs number one, many students had did some research on the mortality rate of the maternal mortality rate in some cultures. And for the United States, where we are with everything, we're actually on the lower end for African Americans and for Native Americans. So I do have this. I don't know if anybody got a chance to look at some of those videos and some of the that information I put on my announcements, but I kind of put it on there just to kind of go through and read through there. It was very interesting. We're going to be addressing a little more of that, but I just wanted to share that with you. And I just kind of went and did a little more research just to kind of show you. This was from Heck et al. 2020. So it's actually very, very recent statistics, and it talks about the gaps and disparities in maternal mortality rate. And I kind of bolded the one section: pregnancy related deaths per 100,000 live births is at 16.7 for the general population. For non-Hispanic, Black, and American Indian, Alaskan Natives, it's 40.8 and 29.7. So it's significantly higher. And I thought this ending piece here, it talks about college education. It says, although education can be protective, Alaskan Natives and American Natives women with some college education have higher mortality rates than other racial ethnic groups with less than a high school diploma. So I thought that was, startling in 2021 that we were still seeing that. And that's just the reference. That's where I got that from. So this was actually, they were actually doing what's called a scoping review, and they were just actually looking to see what does the literature show right now with mortality rates among American Indian, Alaska Native women. And then some strategies for improving responsive care. I liked how that one doctor in the video said it's like the golden rule. It's you want to seek to understand, you want to be respectful, maintain an open attitude, be open, examine your own biases and assumptions, and that just kind of goes across the board. Avoid stereotyping. And your textbook on page 120 went into a lot more detail on it. So I just kind of said that, just kind of revisit that. And I have just one little question here for you. Prenatal classes provide the couple with, so we're just kind of going back, talking about that, that pre-care. So it provides knowledge and confidence, mental health counseling, nursing level knowledge, or a birth plan.
A.
Very good. All right, and I'm just going to kind of wrap up with talking about the exam. So your exam is going to be next Tuesday, and I'll have it open from 9:30 to 12:30. You're going to use Respondus Lockdown Browser, and everybody's been using Respondus Lockdown Browser already, so I think you're all familiar with that. Obviously, no cheating policy. I actually have to go through and I look. Respondus gives me a breakdown of anytime a student like looks away, you know, so like they monitor that, and I kind of have to go through and revisit all of that. I ask that everyone does a room sweep, and I'll tell you, people get really creative on their room sweeps. I've actually I had a laugh at the one because they, you know, a lot of times they'll use like a compact mirror. They'll use the camera on their phone. I literally had a student the one time they had a mirror on the wall as a decorative mirror, like maybe the size of a picture frame, and they went and took the mirror off the wall and used that as their way of doing a room sweep. And I basically the idea behind a room sweep is so that I can see what's on the front of your computer, because like if I'm looking at it, I'm just seeing what's behind, so you wouldn't know. Like right now, I have notes behind my laptop, right? I just put them there. But would you know if I didn't tell you that I have notes behind my laptop?
You can't see them, no.
Right. So that's why you want to do a room sweep. So I'll see if I can. So they did something like they like used the camera, used their phone, and went all around like that. You know, do different things like that. So just different ways of doing a room sweep. Grading, I should definitely have it graded before Sunday evening, but I just kind of give myself a little wiggle room. I have to go through all the exams, and I look at it statistically. So say there's a question that, and I always look at anything less than 50% wrong. So if the majority of the group got 50% of the group got that question wrong, and I have to go through all 4 cohorts, then I go back to that question. Was it a poorly written question? Did I not address it in class? Was there a typo? Did I miskey it? Or was it a really good question that I really stressed in my lectures that, you know, so I look at all of that and I decide, am I going to throw that question out, or am I going to keep that question? Or am I going to accept A and C? You know, maybe originally it was just C, but now that I look back at it, 50% of them picked A. And when I go back to the textbook, you know what? It really does kind of talk about A also. So I have to kind of go back and do those things again. Most likely be graded before Sunday evening, but I do have to wait. You know, I have my Wednesday day and my Wednesday evening has to take it, and then Thursday I try to sit down and get it. Again, most likely they'll be posted before that, but I just like to, you know, put that there just in case there's some kind of issues or whatever. I asked that you know, if a student does want to challenge a question, be really careful. You know, don't, you know, in your email, don't be like, I know this question's right, and you need to go back and revisit it and give me that credit. You know, that's the kind of email I'm gonna be like, let's have a little, you know, before Zoom, I would have said, come and see me in my office and let's look at this together. But we are in a Zoom environment. So I'll just say, schedule an appointment with me. If you do feel there's a question that, you know, you want to challenge, schedule an appointment. And I will ask that you give me 2 APA formatted references to show me why you felt that A was the correct answer. Again, I always put in there to please be respectful when you are sending emails. You know, I always put this in here that I'm recording your grade. Like I hear some people say, oh, she gave me a C, or, you know, or she failed me on the exam. I'm just going to say that for example. I'm just taking what the score is and I'm putting it in the grade book. What, you know, now if I change questions, I do that, but I always, one of my students several years ago said to me, they came from a different program for their LPN, and they said their teacher said to them, every time they didn't get a question correct, it was considered a medical error to that patient, you know, and kind of looking at it like that. Use the study guide. You have my study guide. I had that posted since when we first started. So you got all the PowerPoints there. You have the study guide there. The questions are at a higher level. So they're not like the quiz questions were at knowledge level. The exam questions are at application level. I do hide the grade book and I don't release, like, I have the grades hidden and the grade book hidden until after I go through everything. And then I will post in announcements, grades are all in, and I will open it up. You can't go in like you were able to go in with your med math test. You won't be able to go in and look at the individual questions. If anybody wants to meet with me one-on-one to go over their exam, I do that. I will meet with the students, so just schedule an appointment, and I will do that. I always put this out here because I don't know what other professors do, but for my tests, my SATAs, my select all that apply are all or nothing. So if you have 3 of the 4 correct, but you have 1 not correct, then the SATA question is wrong. So again, I'm not sure what other instructors do, but I just want to reiterate that. I mirror the NCLEX, which is the same thing that the NCLEX does. And your test will be on PowerPoint 1, 2, and 3. So these three PowerPoints. Your CLGs up until this point, but your CLGs kind of mirror the PowerPoint. Let me see if there's anything else I'm gonna stop sharing there so I can, let me just,